Okay, so thanks. New evolutions in mitral valve surgery that keep it the standard of care. And I'm not going to talk about stitches or whether I use a backhand or a forehand. And I'm really going to talk just about degenerative disease. You know, we always, as surgeons, yacked on about if we repaired degenerative disease, we cured mitral regurgitation and so on like that, but we didn't have much data about it. There's not very much randomized controlled trials of repair versus replacement in degenerative disease, and there never will be. And we have studies that look like this, like early surgery versus watchful waiting and so on like that. It's better than just sitting around waiting for something terrible to happen. So what we did was, we looked at the last 1,000 patients that we did that was asymptomatic. So these were just mitrals. They weren't mitral mazes, they hadn't gone into AFib, they weren't a double valve, they didn't have coronaries and so on like this. And we just presented this at the AATS. And we asked the question, in every age that we operated on, 20s, 30s, 40s, 50s, 60s, 70s, 80s, 90s, how do they do compared to the CDC database? Because the average age is 62 that we operate on someone with degenerative disease in the United States. But what if we operate on somebody when they're 30, when they're asymptomatic? Do we limit their life? So we have enough patients that we looked at it, combined some of the decades, and then compared against the CDC waterfall for their survival. So in one group we had 1,000 patients, in another group we had all 330 million of us. In reality, the waterfall was exactly the same. It didn't matter what age you were in when you operated on, your survival matched that of the American population. This includes every mortality, morbidity is taken care of by looking at it this way. If this is the median survival for you if in your 20s, 30s, 40s, 50s, 60s, 70s, obviously when you're 92 years old, you're not going to live 40 years, you can see that. But this is their survival, median survival of patients who were operated on in the same decades at the same exact age, and their survival is the same mathematically as if they did not have mitral valve disease. And I think this is an evolution that we've had as we've been able to show that we are better mitral valve surgeons, that we now operate on patients before they have complications, before they've hurt their ventricle, and we can restore their life back to the point as if they did not have this disease. So DMR mitral valve repair completely restores life expectancy. And I think that's a new evolution in our thinking at any age. So if you operate on someone when they're in their 30s, you can expect them to live as if they did not have mitral valve disease. And that is a very high bar that we have to think of when we move to percutaneous therapies. Now, of course, the downside of that is you have to have good repair. We had a less than 1% recurrence. Our reoperation rate was extremely low. Even counting that stuff, they all survived the same. But again, the biggest predictor of mitral valve repair is the surgeon. You have to make sure that you don't have a patient-surgeon mismatch. And this has been an evolution of how we think about mitral surgery. Mitral surgery is not a commodity. It's not just, I'm going to send my patient to mitral surgery and he'll come back. It's the surgeon, and you have to be careful of choosing and matching that patient for that surgeon. This was our original paper that shows the more you do, the better you are. It's the same for the Medicare population. It's the same. It's not the hospital that does this, it's the surgeon. The hospital effect is washed out by who the surgeon is. It's not the country, it's the same effect in England. It's not just in Michigan, it's the same effect in Virginia. This is from Gaurav and Scott. It's not just Virginia or Michigan, it's the same in New York State. Volume and the surgeon, it's dependent on the outcome for the patients. So, we've had an evolution in our thinking about degenerative mitral patients over the last, say, 10 years that mitral repair restores life expectancy, and mitral repair will be done by specialists. You will see there will be volume and outcome and quality criteria determined to be able to say you are or you are not a mitral valve heart team. I think the last thing that's evolved for us is how we interact with our imagers, and we've learned a lot from percutaneous techniques. This is a 2D. Patient has a lot of MR, but this 3D, I can look at this 3D 6 weeks before the operation, and I can say exactly what I'm going to do. And even more importantly than that has been the interaction with CT. If you asked me 10 years ago how many CTs I got on a mitral patient, it would be 0. But now we get CTs on mitral patients all the time to look for calcium and size and atrial height, thinking about, as the heart team thinks about, is this a percutaneous patient? Is this a surgical patient? And I think this is a stolen image from Paul, that these patients with MAC, who we used to think about as just terror for surgery, we now have different options: open surgery, putting an upside down TAVR into the MAC ring. We're much more sophisticated looking at CT. So I think imaging has been an evolution that has changed how we think of mitral valve surgery. I think soon we'll use different images. We'll use ICE a lot preoperatively or before the procedure to look very carefully. We're changing how we think of ICE baby. We're going to different types of matrix, volume, 4D ICE imaging, and it will give you specific applications for the devices that are going to be on, and also how we think about the anatomy. So mitral valve repair restores life expectancy. Mitral repair will be done by mitral specialists through a heart team, and mitral imaging has improved a lot. Well, how does that relate to this field of percutaneous? Well, the mitral valve is super complex, and of course everyone thought we could just take a TAVR and turn it upside down and it'd do just fine. And I think that we have evolved to think that that won't happen. You know, the mitral clip is fantastic. I do mitral clips myself. I think it's a great therapy. I think we'll look at it 10 years from now and say, this was the gateway drug that brought us, opened the door for percutaneous therapies. But if you think it's going to replace everything we do in surgery as we continue to evolve forward, I think you are drinking the purple Kool-Aid. I think if you think you're going to take a percutaneous mitral valve and replace every valve degenerative, you will absolutely not restore the patients back to their life expectancy, because you are now leaving something to the Diet Coke can inside your heart. Even when I do a mitral valve replacement at surgery, I cannot restore them. I cannot cure their disease. So if you think this will serve every patient, you are drinking the purple Kool-Aid. And in fact, the mitral valve is complex, and I do a bunch of stuff. Every surgeon does a bunch of stuff at their options there. And if you think you will take just one technique, or I will use a millipede, or I will be the mitral clip guy, or I will be the Tendyne guy, I think you are drinking the purple Kool-Aid. And I think we'll see that the gold standard that we have evolved as surgeons will be maintained for percutaneous therapies. And that gold standard is more than one thing. I usually put an annuloplasty ring on a patient when I'm there. I may or may not do something to the cords or the leaflets, and then and only then, if I default, or in certain diseases, I will go to a mitral valve replacement. And I think that will stay the same. I think the catheter mitral toolbox will evolve, but the biology of MR will not change with the method of therapy delivery. So I think I'll end by saying mitral evolution. Surgery has been moving forward all the time. It's not as if we stood still and waited for catheters to catch up. Mitral valve repair now restores life expectancy. We can cure degenerative mitral valve disease. Mitral repair will be done by specialists. That will be both surgical specialists and transcatheter specialists who only do mitral. This is not an upside-down TAVR. Mitral imaging, both for surgery and percutaneous, has evolved and improved amazingly. And mitral surgery itself is evolving. And interesting, with the advent of catheter therapy, we're starting to fuse together and are thinking about how we're evolving together. But evolution is slow, and surgery will remain the standard. Thank you.